Okay.
Yeah, you did.
Hello?
Oh, turn your
Testing. Okay. Ready?
Hello.
Turning it on. Okay, y'all are live.
All right, thanks everybody for joining us for this meeting. Before we get started, we want to make sure we record everybody who's here. So if you would, just put your name in the chat, and that will get it in the system the same as a sign in. And with that, I'll hand it over. Nell?
There we go. Okay. All right.
Would you like to start?
Yes, I would. And I apologize, everybody. You have an agenda that says that Elizabeth Pittman will do the introduction, and I will close us out with closing remarks. Elizabeth and I have been thumb wrestling over this for about 24 hours now. Just kidding. My schedule originally got flipped, and I was supposed to be at a meeting to start today. And so I asked Elizabeth if she would introduce and just sort of kick us off, and then the meeting got changed. So I now will not be here to end the meeting. So I'm grateful to be here at all. So I'll start by saying that. Elizabeth, thank you for your flexibility in trying to figure out who's opening and closing today. Want to just say welcome to everybody who's here in the room. Thank you for being here. Everybody who's online, we appreciate you tuning in for the Arkansas Health and Opportunity for Me for our quarterly Health and Economic Outcomes Advisory Panel quarterly meeting. You know, as you will see as we walk through the information, and you should have received this information ahead of time so that you can see kind of where we are with we're going to walk through our updated outcomes, health outcomes, targets, some incentive information, and we're going to, hear from our partners, our QHP partners on some of the changes that they've made in the past year and how those have impacted outcomes. Also take a look at some of the proposals as we go into 2025. Which is really hard to believe we're already looking at that. I feel like we were just talking about what are the incentives for 2024. But we wanted to just walk through those health quality measures and then walk through the incentives and give everybody an opportunity, obviously, to ask some questions and sort of contemplate, what do we want to do going forward as far as these measures go, and how do we get better together. So again, just appreciate everybody's time. And, as always, Nell and Elizabeth and Dennis and everybody who's worked on getting a list together, we thank you for the many hours that it takes to put together all these charts and all the information and to make sense and make sure that we can walk through and understand and get a clear picture of what's going on. So thank you all.
Before we start, did Gavin ask everyone in the chat?
He did.
Okay.
Yes.
Thank you.
And let's see, we've got 23 people online, and we've got like 11 chats. So if you haven't already put your name in the chat, please do that. Okay, so welcome everybody. This is the ARHOME Advisory Panel meeting. Advisory panel members and others are joining via Zoom. And just a reminder that Arkansas PBS is live streaming this, so you'll be able to watch and rewind for all the important bits later. And some people may be joining via that live streaming. As Secretary Putnam said, the meeting focus is on the Health Improvement Initiative. We're going to review the 2023 health quality measures, and then we're going to review the health incentives that QHPs offered in 23 and their proposed incentives for 25. And I will also just mention, probably more for the people in the room, if you've brought slides that were emailed to you, I added one slide, so you might be one slide off. And we're going to go to Jen Dedman.
Thank you. Hi, for those of you who haven't met me yet, I'm Jennifer Dedman, and I am going to be eventually taking over the care of the ARHOME program from Nell. So I'll present our quarterly report today. It's required by the act that created ARHOME, Act 530 of 2021, and it requires this quarterly reporting to this advisory panel on the program's progress towards meeting economic independence outcomes and health improvement outcomes. And the report has to have certain information, which you can see listed here. So that is what makes up our quarterly report. As we know, the carriers set the premiums that they charge for each plan that they sell on the marketplace, and those are subject to approval from the Arkansas Insurance Department. All of the ARHOME QHP premiums are expected to increase in 2025. DHS and CMS control the cap on the total program costs, and that's our budget neutrality limit. The total costs do include dental and vision for 19 and 20-year-olds and non-emergency transportation. The 2025 budget neutrality limit was established with a 5% increase. So here's the change in premiums that we expect to see for 2025. I'll give you a moment to look at those. You might be wondering about these increases. We talked to the QHPs, and the word that we received was utilization, the experience of 2023, and also the impact of an emergency rule 128 on pharmacy dispensing. What that rule does is it makes a requirement for the dispensing fees for a pharmacy benefits manager to be paid from to ensure reimbursement that is reasonable. Currently, we do not have a limit set, but this would require those payments to be within a close range to minimums of the national average drug acquisition cost, or NADAC. That's $9 for brand name and $10.50 otherwise. We do have some additional context for those premiums. So we're looking at two things here: comparison with the marketplace and comparison with Medicaid. In the marketplace for 2025, across 324 marketplace insurers participating in all 50 states and DC, the median proposed premium will increase by 7%. Provider reimbursement rates tend to play a larger role in those premium increases than utilization rates, but we're also looking at things like economic inflation, hospital market consolidation, and workforce shortages. When we turn to Medicaid, following the end of the PHE, the decline in Medicaid enrollment mainly occurred in the non-elderly, non-disabled adult populations who use fewer medical services. So we're seeing the younger, healthier population leave. And nationally, Medicaid is spending per enrollee more. So you're looking at a growth estimate of 10.2% in 2024 and an average of 5.8% annually in 25 and 26. There's a link there at the bottom, a couple of links if you want to check out more. This is our source information. Okay, any questions? Okay, I'll turn it back over to Mel then.
Thank you, Jen. Okay. So this is the slide that I added as context for the whole conversation that we're going to have. And this is sort of the components of ARHOME accountability. That we have measures, incentives, targets, and penalties. So the measures, an example is percent of women who received a mammogram. That's how we're measuring the QHPs. Each year we're calculating these measures. Then we've got incentives where we're requiring QHPs to offer incentives, and that might be a dollar amount for beneficiaries who receive a mammogram. So a financial incentive to beneficiaries to do the thing that we are hoping that they do for their health and for the plans. Then we have targets for the QHPs. So the targets must ensure, this is an example, that they must ensure that at least 54% of women receive a mammogram. So that's a target based on the measure. And then we have penalties. So if the QHPs at the end of the year haven't met a sufficient number of the targets, there is a penalty of $1 to $5 per member month that's assessed against QHPs. So that's sort of in a nutshell how we handle accountability in ARHOME. And so you're going to see all of those things, not penalties. You'll see penalties in December, but you'll see measures, the incentives, and the targets. So just an overview of the activities, just to give you kind of a time frame for this. In December of 2022, we set the targets for the 2023 performance targets, and we based it on 2019, 2020, and 2021 performance results. Today, we're going to review those 2023 performance results for half of our metrics, 10 of our metrics. And then we're going to review the results of the health incentives that the QHPs offered. So essentially, we're going to see what did they offer, and then what was the result based on the measure. And we're also going to review their proposed 2025 incentives. And then in December, in our fourth quarterly meeting of the calendar year, we're going to continue to review the 2023 performance results. Of the ones that we have left to do. We will review potential sanctions for 2023 performance. We're going to set the 2025 performance targets, and we're going to continue to hear the additional incentives that the QHPs will offer in 25, and we'll review their strategic plans, which are required under the ARHOME statute. So this is of the four components. These are the incentives. In 2023, QHPs were required to offer 2 health improvement incentives for each focus area. So preventive care, pregnant women, individuals with mental illness, individuals with substance use disorder, and those with 2 or more chronic conditions. And I should have done the third one in a different color, but the ones that are colored are the ones that we're talking about today: preventive care, substance use disorder, individuals with 2 or more chronic conditions. And the QHPs, in addition to offering these incentives, they must include those activities in their annual strategic plans, which again, we'll hear in December. So these are an explanation of the targets. We have in 2023, we set 3 kinds of targets. One was based on the best performance. So it's looking at 2019, 2020, and 2021. And you can see in the sample measure, the best performance is that 27% measure. And so that is our best performance measure. So that's the measure going forward. So the idea is if one of the QHPs can get scores like that, all of them can, and we're going to set the target to the highest performer. The second kind of target is the median target. So it's looking at those same performance numbers and saying what's the median number within those 3 years and those 5 QHPs, and that's in yellow. And the last one is the improvement target, and the improvement target says, okay, what was your performance in the year, and you have to improve by 4%. So these are all the median target. Obviously, the best performance target is what we want them to be, where we want them to be. Median target was something that we did because the QHPs were saying we can't all meet the best performance, so we gave them a median target. And then the others said, oh, improvement is what's important, so we gave an improvement target. And each of those targets for each measure receives a certain number of points. We tally the points at the end of the year, and if they achieve above a threshold, then they don't have penalties, and then they're increasing penalties depending on the number of points. So that's target setting. And you're going to see targets throughout on the slides, and that target is the best performance target. So we are not showing on the slides the median or improvement targets. It's just the best performance target. So before we get into the actual results, QHPs have frequently said, oh, our population is more like this or more like that than the other people. So we've created a slide to see the truth or not of that kind of statement. And we do find that there is a difference in, you can see that this is the red is ARHOME overall. The blue lines are the QHP, the Blue Cross Blue Shield QHPs, and the green are the Centene plans. And so I could get it all on one slide. I've got just sort of half of the story for all of the demographics. But you can see that they're basically very similar except for age. And Health Advantage has a younger population, and Blue Cross Blue Shield has an older population. Ambetter has a little bit older population. So that's the one area where there's pretty significant difference. Otherwise, they're very similar. Okay, so preventive care, we have 3 preventive care measures. We're only going to go over 2 of those today. That's breast cancer screening and cervical cancer screening. So this is the breast cancer screening. It's the percentage of women ages 50 to 64 who had a mammogram in the last 2 years. So it's not just in the years, in the last 2 years. And this slide shows the trend from 2019 to 2023. ARHOME overall is in red. The race breakdown is in blue, and urban and rural is in green. And black is the target for each year. So the best performing target for this year is 54%. So after some declines in the rates from 2019 to 2021, we see an increase in this measure in 22 and 23, which we assume is coming out of the pandemic, people going back to their providers to receive their routine care. Although you'll see some other measures where that same theory doesn't hold true. Black women had significantly better rates than white women, and that is true across all of our 3 preventive measures. And that appears to be the same thing that we're seeing around the country as well. While overall cancer screening rates are lower for blacks than whites, the comparison is reversed for breast and cervical cancer screenings, the ones that we're actually measuring and monitoring. There's very little difference between urban and rural women, and the ARHOME measure is higher than the Arkansas Medicaid total. And I should say, if anyone has any thoughts, anyone wants to jump in, anyone online have a question, please feel free to shout it out. That will, I much prefer to have a conversation. So, breast cancer screening. Okay, so the data for each measure each year is represented by different colored bars, and these are the health insurance plans, the 5 health insurance plans. We actually have 6 health insurance plans, but one just started in 24, so it didn't exist in these years. And then Health Advantage started in 21, so sometimes you'll see that they don't have data for earlier years, and that's because the way the measure was structured, but they didn't exist until 2021. So the good news is that all 5 plans are making progress on this measure. The Blue Cross plan did better than the Centene plans across all 4 years, but Blue Cross's other plan, it's the Health Advantage with its younger demographics, did about the same as the Centene plans. This is the cervical cancer screening. This is the percentage of women ages 21 to 64 who were screened for cervical cancer using, it's either 3 to 5 years, depending on the woman's age. So it has a very long look back and is sensitive to churn that happens in Medicaid.
Because that's something I think we talked about during prep is this indicative of there was a change to the recommended periodicity of getting these screens. So that does account for the differences in how regularly they're supposed to get. Yeah, I mean, for the QHP, they're looking for if the person wasn't in the plan for 3 years, or they got their cervical cancer screening 3 years ago, but they've only been in the plan for a year, they're not going to be counted in this measure. Yeah, yeah. Okay.
So This is obviously not going the same way that the breast cancer screening measure was going, where there was a bounce back after the PHE. But this is in line with commercially insured rates and for Medicaid HMOs, that they are not bouncing back as fast as the breast cancer screenings. So there's more to figure out about why that might be happening. Okay, so this is the QHPs and how they did on the cervical cancer screening. So the rate for ARHOME overall is reducing, but each QHP's rates improved in 22 over the previous 2 years. And Blue Cross had the best rates, while Health Advantage, which offered the same incentive for cervical cancer screenings, which we'll talk about in a second, had the worst. And these, again, this may be affected by the long look-back period. Okay. So these are the incentives, the preventive care incentives that each of the QHPs offered in 2023. Blockage here. So you can see that that Blue Cross offers, they offered a financial incentive for cervical cancer screening and for mammogram, and I believe this was an increase from earlier years where it was $30, and the percentage of uptake, which is in the beneficiaries awarded percent of eligible column, they've got pretty good uptake of that particular incentive. And then this is for 2025. So Blue Cross is adding a new incentive for chlamydia screening. And again, we'll talk about chlamydia screening in December. And Ambetter is providing incentives for a variety of clinical activities, including the equivalent of $25 for cervical and breast cancer screening. And QHPs, if you guys want to hype up and say anything about why you're making the changes that you are, feel free to hop in.
Simply based on the need, I think we reported before that for the incentive program for Centene, we identified that the challenge was more so that the member was not really utilizing the program properly. And so we had to really amp up the education through videos and outreach calls. So it was less than the financial incentive, but more in getting them engaged in the program that we had, because they just simply weren't utilizing it. And so we spent a lot of time and effort and resources to reinforce what program we actually had available. And I think we've made some progress. If we can put things on our website and send out mailers, et cetera.
And I would add, we do incentivize a little heavier toward wellness exams, because if we can get our members to build a relationship with their primary care doctor, then, that primary care doctor will hopefully assist in many of these other things, making sure they do get those proper screenings, handled. So that's why you see a little bit more emphasis there on that wellness exam, because we're trying to get them in with their primary care doctor.
And for Blue Cross, excuse me, we saw good engagement with our current incentives in breast cancer, cervical cancer, so we wanted to do the same to drive up chlamydia screening rates. We see our members are asking questions about their to-do list, and they're trying to complete their screenings and check that off. So there was really good engagement for those that are on the portal and redeeming those gift cards.
So this is just a summary of the things that we've already talked about. That's more for the people who missed the presentation. Okay. So substance use disorders and behavioral health, we have two today that we're going to talk about. So the first one that we'll talk about is follow-up within 30 days after an emergency department visit for alcohol or other drug abuse. And this is, they follow up with with someone, with a, with a professional who is familiar with treating these sorts of conditions. So you see a giant increase in 2022, and that looks really good, but it's mainly due to a methodology change in 2022 for this measure, where a number of procedure codes were added as having met the metrics. So we'd like to think that was a really good work, but it was really just probably a methodology resulting from a methodology change. And then in 23, unfortunately, we're seeing a significant decline that we're not exactly sure why that occurred. The white clients had better follow-up rates after an ED visit than Black clients, and that's something that we've seen historically with other metrics for mental health treatment. And urban clients had slightly better follow-up rates than rural clients, which is a switch from what we saw in 2022. This is the QHP performance on that same measure. While all QHP's rates decreased, the Blue Cross plan continued to have better follow-up rates than any of the other plans. One of the questions that we had talked about in planning for this meeting was the numbers of people, and statewide, we're talking, the denominator in this measure is about 1,700 people. So it's smaller, obviously, for each individual QHP. But it's not tiny. Okay, so this is the incentives for substance use disorder, for members with substance use disorder. And you'll see that Blue Cross has one that's directly targeting the measure that we just talked about, which is $100 for completing the follow-up visit after an ER visit, and then they have $50 for completing follow-up visit receiving medication-assisted therapy. And they've got lower than, I think, the screening measures, but still, there's more to do, but yeah. And then for the Centene plans, they don't have a specific incentive. They were using something called HALO, which I believe it supports members at risk for substance misuse and substance use disorder, and provides intervention across the recovery continuum. And they also do a lockout program. This is a program where they the person who's going to multiple pharmacies is identified and is locked into one single pharmacy. But again, it's not exactly an incentive. Okay, so this is 2025. So we were just looking at 23. This is 25. The Blue Cross is keeping the $100 for follow-up after SUD visit in the ER. And then I think this is a change. This is a $50 incentive for members with substance use disorder who use peer specialists, have virtual SUD treatment, or other treatment options. So that's, and I don't know if you want to talk about why you.
Yeah. These are really timely incentives. So just like the measure, it's 30 days and then they're not eligible. So what we're wanting to do next year is promote and educate throughout the year. So especially with the substance use disorder treatment. So offering those options like peer supports, seeing a substance use provider or virtual treatment. We can incentivize any time of the year, regardless of the initiation engagement of substance use disorder treatment measure, which is so timely, 34 days. So this would allow you to display that throughout the year, and we give $50 to more members for seeking those options and trying to prevent events from occurring and getting treatment. The follow-up one, that one is better performing, so we're keeping it the same. We're just adding hospitalization follow-up to that, so we'll also extend that to those members as well.
And then Centene, again, doesn't have a specific incentive, but, and I think this transitional care management program is different from the HALO program, or is it?
No, I think
No.
that one is potentially the same. But we do have a couple other programs we are working to implement that aren't listed yet just because we haven't got them finalized, but they will absolutely target this particular population and measure on those follow-up visits, both after emergency room, after hospitalization. So, you know, we're definitely looking at some additional opportunities through some programs that we plan to implement to help target this specific measures. But you're right, we do not have any monetary incentives in place for this population. But we do see a good performance out of our programs that we run. The pharmacy walk-in program, that's been in place for several years with us. When we put that first in place, we really saw a reduction in these measures. So you don't see it as much year over year because the plan it's already there, it's in place, and many of these members have been locked into these pharmacies for quite some time. And we do let them change if they move or, you know, something like that, but it really does keep them into a single pharmacy so that those scripts are better managed and we know what's happening there.
And I'll just add that, you know, compared to our competitor here, it looks like we don't have any financial incentive available, but in reality, we're trying to holistically care for that member. You know, if they're hospitalized or if they are in the emergency room for substance use disorder, they actually need to be monitored and cared for properly through that transitional care management program. And so that approach is long-term, and it also includes education on the follow-up, the 30-day follow-up appointment. So it's not so much as we're gonna dangle a dollar in front of you, it's more so, let's figure out how to support you, so.
This is not one of the questions that we asked you guys to provide to us, but do you have any sense of successful completion of treatment and, you know, kind of the relapse rates? Do you have any general sense of that, or is that something that?
We can provide that. We do not have it just on hand and we can't speak to it, but I'll tell you the engagement, the completion of the program is pretty consistent for the members that engage, but it is difficult to get members to engage.
Right.
You know, it's a very sensitive topic, and when you're making outreach regarding a sensitive matter, sometimes members are just simply not interested.
Right.
So we can provide a follow-up, but the ones that we do get engaged, they have a pretty successful run.
Just a point of curiosity on my part. It's not, like I said, it's not something that we would ask you guys to report on, but I'm just to get a sense of how successful are we being with the actual treatment. It would be good for us to know.
And I'll say that our peer support specialists, they've had substance use disorder conditions before, they're recovered, they're on the ground in different areas of Arkansas, meeting members at facilities and walking them through, helping to facilitate recovery and continue that path. So that's the purpose of the peer supports, but we can get that for you as well if you're curious about it.
Yeah, I would like to see it. No rush, but just when you have an opportunity.
We have those information. We track that.
Yeah, thank you.
Okay, so concurrent use of opioids and benzodiazepines. So this is the percentage of beneficiaries with concurrent use of prescription opioids and benzodiazepines. So the denominator is those people who have more prescription, 2 or more prescription claims for opioid medications. And then once you've got that denominator, then you're looking at who of those has an overlapping benzodiazepine prescription. And it has to, the opioid prescription has to be at least a supply of 15 days or more. So that's it's not that 24% of all people have a concurrent use of opioids and benzodiazepines. They start with who's got opioid prescriptions of 15 days or longer, and then who's got an overlapping, of those people, who's got an overlapping benzodiazepine. So this is actually moving in the right direction. Although there is a very wide disparity between Black and white beneficiaries, with Black beneficiary rates being much better than whites. That's overall. This is QHP. So again, while there was improvement overall for ARHOME, no QHP met the best performing target on this measure. Blue Cross continued its improvement, while Health Advantage, QCA, and Qual Choice continued to worsen. This is the slide for the people who missed the presentation. Moving on to chronic conditions. So all of the measures that we're going to talk about are hospitalizations for a chronic condition. So the idea here is that if the chronic condition were well maintained, then the hospitalization would not be necessary. So you want low hospitalizations as a result of these chronic conditions. So the first one is hospitalization for diabetes, short-term diabetes complications. And this is, we've been seeing percentages. These are hospitalizations per 100,000 member months. So you can think of 100,000 member months as like about 8,300 people who were enrolled for the whole year. So that would be, if you've got 30 hospitalizations, the way to think about that is 30 hospitalizations within a population of 8,300 people who are enrolled the whole year. So that's just to put some context to the numbers. We obviously, it was moving in the right direction. 23 has a significant uptick, particularly in the Black and the rural population, but really all around. We don't have anything to compare that against nationally just yet, so we don't have a reason for why there was that uptick. But we're going to dig into the data and see if we can come close to understanding what's going on there. This is same measure, but for QHPs. So the uptick in the rates is coming from the Ambetter and Qual Choice plans. Those are the ones that increase the most, but none of them are as high as the increase in the ARHOME overall population, which likely means we're talking about the medically frail individuals and the people who are in the intermediate, the temporary benefit plan, Medicaid fee for service, while they wait to enroll in a QHP. So that is another interesting and something to look further into the data. Okay, so this is hospitalization for COPD, cardiovascular. It's, yeah. Sorry. Chronic obstructive pulmonary disease. Thank you. Well, I've got it written right here, but I thought I could just, or asthma. So we're talking about respiratory issues, and I don't know why I said cardiac. Respiratory issues for older adults, 40 to 64. guess that makes me an older, right smack in the middle of that. So I'm an older adult. So the ARHOME overall has made improvements in this measure. And slight increase in 23, but overall it's moving in the right direction. This is the same measure, but by QHP, and all of the QHPs had slight increases, except for the Qual Choice plan, which improved slightly, and the Health Advantage plan, which worsened significantly. But that said, all QHPs met the target. So this is hospitalization for asthma for younger adults. And one thing that is not apparent on the slide, because I was playing with the scale, but there are significantly lower hospitalization rates for asthma for younger adults. So we're talking, essentially 2 in 23 compared to like 20 and 25 in for the older adults. But this is, again, going in the right direction, going down. This is hospitalization for asthma in younger adults, but for the QHPs. So none of them met the target except for Health Advantage. And you can see significant increases. Although, again, we're talking about scale, the numbers are, they look larger than they are when you look at 1.5 to 2.8. Obviously, that's twice as many, but they're still small numbers.
And just to add, I did look at that, just to give a context, like Qual Choice, that's 1.2. That was 3 members. So it's very small numbers, so it doesn't take but 1 member here or there to move that up and down pretty significantly, because there are just very small numbers here.
All right, so this is a slide that is looking at those 2 measures that we just talked about for adults and for young adults. And what has struck me about the patterns are that for young adults, the Black population have worse rates than the white population, but it's reversed in older adults. And I think last time, Dr. Golden, we talked about smoking rates in Arkansas, and that has a role in this. But it's just an interesting and something for further review of why are those switched the way that they are. In 2023, the white population got slightly worse than the Black population rates, but still it's just an interesting pattern.
Maybe partly just law numbers, because the younger adults numbers are so small. It could, flip back and forth every single year.
Makes a huge difference.
One makes a huge
right.
Yeah. Where there's definitely more members that fall into the older adults category.
So this is our last measure. This is hospitalizations for heart failure. And these numbers, again, are kind of a mystery to us. They got a lot worse not a lot worse, but they got worse in 2023, particularly in the Black population and the rural population. We're going to do some digging to see, are those the same people? And is that, driving that very similar pattern? But the white population also increased. The urban population was the only one that decreased slightly. So this is that same measure, but for the QHPs. All of the QHP rates worsened for this measure in 2023. QCA and Qual Choice had the best performance while Ambetter and Health Advantage had the worst. And then this is their incentives for chronic conditions. You can see that in 2023, Blue Cross had 15 for blood pressure and reading an educational article, 40 for achieving a hemoglobin A1C test of 7% or less, and then $50 for maintaining, this is the asthma medication ratio, 0.5 or greater. And you can see they had very good uptake on the rescue inhaler issue. I'm guessing that's one of the reasons that you're not doing that one again this year.
It's just not timely. It's the end of the year when that's calculated. So motivating someone to continue that pattern throughout the year is difficult. And we know we wanted to focus on heart failure. So that's the reason. And we perform well on that measure overall.
Yeah. And Centene has challenges on their portal that they members can receive points for, and had some problems with uptake, but I think that's outreach and understanding how to use your portal. So this is 23. We sort of talked about that at the end of, so it takes a little time for those realizations to then impact the measures. Okay, so these are 25. We kind of talked about this a little bit already. Blue Cross is adding one for follow-up care following hospitalization for heart failure and keeping the diabetes incentive. And then Centene is awarding providers $100 to $300 for completing and submitting an appointment agenda as part of continuity of care program, and $100 per member for completing an in-office assessment and documenting all the care omissions that have been addressed. And that sounds like a CMS. It sounded like a CMS structured,
I think, yeah,
program.
you're right. And it kind of goes back again to that whole concept of building that relationship with the member and their primary care physician. So both targeting it from a member incentive and then also from a provider incentive to outreach and try and get these members in, get all those cares addressed, those care gaps addressed, et cetera. So kind of that two-prong approach to attacking the problem. Because again, I think that's what we find many times is these members don't have a relationship with a primary care physician that is overseeing their care, managing their care, making recommendations with them about what, services they need to have done. And so getting them more engaged from that perspective should have an impact throughout all the measures. So that's the what you hope happens. So that's definitely a challenge, though, is getting these members, because most of these members come to us without a primary care physician. So without one, they get assigned to a primary care doctor, and then that doctor can see they're on their panel. And so then the incentive is to reach out to them and get them in. So this population specifically is a little more challenging just because of that. Most of the time they don't have a primary care doctor established.
And we're trying to do the same, and we're gonna give them $50 if they have a follow-up for even a wellness visit, just to address their heart failure beyond hospitalization. So mirroring our rural reward for establishing care, but addressing heart failure here specifically.
And the measure is on prevention. So I thought it was kind of interesting that you're choosing to on the back end of a heart, because
It probably had a lot of words when I sent that to you, but it was in there that it's visits too. But yeah, no, we're trying to be proactive about it too.
Okay, so these are the overall results, and this is for the targets that we've been looking at. This is the best performer target, and you can see that in green we've got the QHPs that met the target or most of the QHPs met the target, and you can see there's just 3. And then we talk about those where no QHPs met the target or most QHPs didn't meet the target. And that's where most of the measures fall. And then there's one that is mixed results. And we'll see kind of a difference with different targets. So the next one is the median target. And again, this one was created to give us a lower bar. So if a QHP can't reach the best performer target, maybe it can get some points for hitting the median. So we would expect more QHPs to meet the median, and that is the case. It looks like 6 were either all the QHPs met the median or most met the median. Only 1 where nobody met the median, and then 3 for mixed results. And then this is interesting. It's the 4% improvement target. So 4%, the QHPs will tell you, it is a hard goal to meet. We're not talking about 4 percentage points. We're talking 4% of each measure. So only 3 measures were in the all or most meeting their improvement targets. 2 were in the no meeting or most didn't meet, and then looks like 5 that had mixed results. So those will be part of the overall. When we start looking at the rest of the metrics, we will add up the points for all of these targets and the achievement on these targets, and in the next meeting say what the penalties look like they're going to be. That is the end of the measures and the incentives and the targets. Anybody have any questions or any additional thoughts? And Christy has to step out. She's going to miss the last most important slide here. So the next activities, we're going to be meeting in December. A date and location have yet to be determined. The meeting topics will be continued review of the quality measures, review of potential financial penalties for failure to meet targets, continuing review of the incentives, and any improvement that, any changes that you guys want to make after the conversation today. And then the presentation, QHPs will present their QHP strategic plans. So you guys will present I think that's the first time I've told you that, but you can probably guess. And then we'll set the 2025 targets. And that is all that we have today. We very much appreciate everybody joining online. Any last parting words or thoughts that anybody wants to share? Oh, thank you to the Arkansas PBS for live streaming our meeting. We very much appreciate it, and hope that everybody goes back and rewinds and really enjoys the presentation. Thank you so much, and thanks to everyone here. Thank you.
We get a tote bag.
I love the tote bag.
I think we're still in.